Our lecture today is on epilepsy. So we'll go through common causes of seizures, a classification of seizures, and the next time we'll go over the anticonvulsant medications that are used to treat epilepsy. So seizures are very common. You can see that 9% will have at least one seizure in their life. That's pretty high. And overall, if you just look at nursing home residents, 10% are on at least one seizure medication. So what is a seizure? It is an electrical hypersynchronization of neuronal networks in the cerebral cortex. And I underlined cortex there because seizures are a cortical process. It's irritation of cortical neurons. So for example, someone that has had a cortical stroke, like a middle cerebral artery stroke, that is something that will often lead to seizures later on. Whereas if someone has a small subcortical stroke, like a pure motor stroke, that is very unlikely to lead to seizures. So epilepsy, the term is used when someone has recurrent ongoing seizures. So when someone has one seizure, that does not mean they have epilepsy. So you can just see here just kind of roughly that notice we do tend to see quite a lot of seizures in younger children. So for example, febrile seizures are very common. A number of childhood epilepsy syndromes are common. And we see a lot of seizures in older individuals. And that is from any insult, especially stroke, that's involved the cortex of the brain. So there are several ways at classifying. One is by etiology. And so symptomatic, the term is used when the seizures are secondary to a structural lesion that involves the cortex. Seizures are then really best thought of. So when someone has a seizure, your job as a physician is to find the cause. Provoked seizures means that something has triggered the seizure. So very often we'll see this related to medications, especially any benzodiazepine medication. So maybe someone is taking quite a lot of that for anxiety or for sleep, and then they go on vacation and forget their benzodiazepine medications. And that withdrawal effect will often lead to frequently a flurry of several seizures. Same thing with alcohol. So if someone abruptly stops consuming what had been quite a high quantity of daily alcohol, then they may have a seizure. And again, often a flurry of seizures in that withdrawal stage. So provoked seizures you don't treat with anti-epileptic drugs. One common type of provoked seizure you should know about is febrile seizures, which are extremely common in infants and children, usually by the age of 5. This is often associated with human herpes virus type 6. And so high fever triggers a seizure. Overall, really good prognosis. Only a slightly increased risk of epilepsy into adulthood. So for the most part, these are not seizures that recur later. Oftentimes we can't find the cause for someone's epilepsy. Brain scans are normal, there's nothing structural, and so there we would diagnose idiopathic epilepsy, meaning we don't know the cause. And especially in children that have seizures, it frequently is hereditary. Now, the classification, though, that is most helpful and the one we'll spend the most time on in this handout is the International Classification of Epileptic Seizures. The ones that boards still use most often is the original classification from 1981. This has been revised multiple times, and actually the last revision I think is a lot more helpful. I've put that in parentheses here, just in the partial seizure category, because I think it's just a more descriptive of what's really happening. So when we look at this classification, the reason it's important, well, there are several reasons. One is if we put someone in a partial seizure or a focal seizure category, we're going to treat that with different medications than if we're putting someone in a generalized seizure category. All right, so the diagnosis here is really important. In fact, some of the medications that we might use to treat generalized seizures, if you use a medication that instead works for partial seizures, it can actually make the generalized seizures worse. So it guides our therapy. The other thing that I think is just helpful is that if you really understand the seizure classification, then when you talk with someone who's had a seizure, it sort of gives you in your mind the questions to ask, the things you want to know on the history. One other just important point about this is naturally when we see the term partial seizures, you might tend to think, oh, that means it's small, and generalized seizures, you might think that that means big. And that is absolutely not what it means. All right, the names here mean that in a partial seizure, it begins in a focal part of the brain. Okay, and that's why actually the new classification we call these focal seizures is, I think, a lot better, because partial just kind of implies something that, isn't really what's happening. Generalized seizures occur when the seizure activity happens throughout widespread cortical areas at the onset of the brain, at the onset of the seizure. So again, a partial seizure or a focal seizure might begin in the temporal lobe or the frontal lobe. Generalized seizures begin throughout the brain. And so we'll go through here starting with partial simple seizures or focal aware seizures. And so as the name indicates here, the more helpful classification, focal aware, these seizures occur without any alteration of consciousness. The patient is awake and aware of what is going on, and so usually the patient will refer to this as their aura. The patient will say, oh, I know I'm going to get a seizure when this happens. Well, actually that aura is a seizure. And if we have the patient hooked up to an EEG where we're monitoring their brain activity, we can see that it actually is just reflecting that seizure onset. And so the symptoms then just depend on where in the brain the seizure begins. So if it begins along the motor strip, the patient, let's say it begins along the facial area, the motor strip, the patient will have some facial twitching on one half of the face. And then if the seizure activity spreads, it may involve the arm. And then now the arm is twitching. So again, the patient is awake and aware. And so if the seizure focus then spreads to the whole rest of the brain, then the patient has what we call a secondary generalized seizure. But it started out as a focal aware or a partial simple seizure. Now, if it begins along the sensory strip, then the patient will complain of some, usually kind of an odd feeling of numbness on one half of the body, or a feeling like there's a breeze blowing on one half of the body. And I'm sorry, that would be if it's a somatosensory. Okay, if it involves a visual cortex, like a patient that I saw some time ago who has this tumor here involving the right occipital lobe, then the initial symptom is visual. And so what he experienced was sort of a bright light that occurred off to the left, and it kind of grew and became big like the sun. Okay, and so that reflects the seizure activity starting the occipital cortex, and as it got bigger and bigger, the seizure focus then spread to the rest of the brain, and then he had again what we call a secondary generalized seizure. If it begins near Heschel's gyrus, then patients may initially have some auditory sensation, usually a crude buzzing, hissing sound, but occasionally these neuronal networks can fire in a way that triggers stored memories for certain pieces of music. I had a neurology colleague who saw a patient for years who heard the Looney Tunes cartoon theme at the onset of a seizure. And I have a patient who hears the opening of Dvorak's New World Symphony. And again, he says, that's when I know I'm going to have a seizure. So it's triggering that auditory memory. Gustatory, olfactory are very, very common. So the uncus, remember, is the most epileptic part of the brain. And so when seizures begin here, it's never a pleasant taste or smell. It's always foul. Burnt rubber is kind of a classic description of that. And so the first time that a patient experiences this, they're asking, coworkers or family members, do you smell that? What's going on? But then as they have, more of these, they begin to recognize that they're actually having a seizure. If the limbic system is involved, then we get these so-called psychic seizures. So deja vu is very common. Now, I always need to reassure students when I talk about this because we have all experienced deja vu. But deja vu, when it's part of a seizure, tends to be extremely intense, often associated with a strange dream-like feeling. Jamais vu is exactly the opposite. It's a feeling of intense unfamiliarity in a familiar place. So the patient's at home, and all of a sudden they just get this intense feeling like they've never been here before. Fear is actually a very common partial simple seizure. And so patients have just an intense anxiety feeling. And so, of course, usually when someone experiences fear and anxiety, that's not going to be a seizure. But it is important to recognize that this is very common because sometimes when a patient just describes, boy, I felt very panicky and then I passed out, we might assume that, they just had a panic attack, right? But we want to keep seizures in our differential here. Anger can occasionally occur, but you should know, since this is sometimes used as a legal tactic, that purposeful acts of violence, like strangling someone, stabbing someone, does not at all suggest a seizure. Okay, you could potentially, if you were to stick your head in the clutches of someone having a seizure, you might get hurt, but it doesn't result in any purposeful actions. And rarely it can cause intense sexual arousal as the kind of the first symptom of a seizure. All right, so coming back to some anatomy here from the first year, let's assume that someone has a seizure focus here in the left hemisphere in the frontal lobe. And so remember, here we've got a cortical spinal tract. So if it's along the precentral gyrus, the patient will have shaking on the right side of the body. All right, but remember the frontal eye fields here on one hemisphere are always trying to drive the eyes in the opposite direction. But normally they're counterbalanced by the opposite hemisphere. But if you have a seizure, then you're going to overstimulate the left frontal eye fields in this case, which is then going to activate the opposite PPRF6 nerve complex. That's going to move the right eye to the right, and it's going to move the left eye via the MLF and the third nerve also to the right. Okay, so if you're able to observe someone having a seizure, or you have a really good witness who's carefully, observing what's happening, if the eyes then are looking at the shaking arm and leg, then that tells you that the seizure focus is in the contralateral hemisphere. So if we have a left frontal lobe seizure, the right side of the body will shake and the eyes will look to the right. Right? So we would know then by the history where the seizure onset occurred. Now, often what happens is someone will have a seizure focus, like let's say temporal lobe, and they have deja vu, or maybe they have that foul taste or odor, and they're aware of it, so it's focal aware or partial simple. But the seizure focus may then spread to involve more of the brain. So the patient may go from a focal aware seizure to a focal impaired awareness seizure. And boards will still use the older term here, a partial complex seizure. Okay, so again, by definition, these patients are not normal cognitively during these seizures. And so what really tips it off historically, if there's a description of automatisms. Automatisms are stereotypic, repetitive movements that for each individual patient, they tend to have the same type of automatisms with each seizure. So lip smacking is very common, where patients will kind of open and close their mouth, smack their lips, or have chewing movements. Picking at clothes is very common. I have a man I see with epilepsy, and I've seen several seizures in the office, and he usually tries to straighten his tie during a seizure, even if is not wearing a tie, or he might kind of pick at his shirt. Nose picking is a kind of an unfortunate automatism, and the videos which are on Canvas I would really encourage you to watch those. But one of those you'll see is a man kind of vigorously picking his nose. And so what you want to hear, if like in this case of nose picking, is someone who is there with the patient. Because if they interact and say, hey, what's going on? What are you doing? The patient should appear kind of goofy and confused, and they don't respond normally. Okay, so that would be a partial complex seizure. And if the seizure focus then spreads from there to involve the rest of the brain, we call that a secondary generalized seizure. And again, the more helpful term here, descriptive term, is a focal to bilateral tonic-clonic seizure. And so what does a big seizure look like? So the older term, but it's still frequently used, is a grand mal seizure, which means big bad. And so oftentimes the earliest symptom of a large seizure, like a secondary generalized seizure, is crying out. And that is because the diaphragmatic truncal musculature tends to contract very early in a seizure. And so many times that's been helpful to me. The patient was watching TV and his wife heard some very strange vocalization which caused her to come in to see what was going on. So that was the first symptom then of a seizure. Patients then tend to merge into what's called the tonic or the stiff phase of the seizure. Oftentimes the arms will elevate and kind of pronate in. They will tightly clench their fists. Their legs will be very stiff and tight. And then they merge into the clonic phase of the seizure, where there's just intermittent relaxation of the tonic phase. So this is the shaking phase. Most seizures in adults are short, 1 to 2 minutes. Now it's very interesting when you watch someone have a seizure. This can be terrifying. Your blood pressure goes up. You want to do something. And so usually when you ask family members how long did it last, they tend to add or multiply the time. So the actual event was maybe 30 seconds or a minute, and they will say it lasted about 5 minutes. So just that you're aware of that. A couple of things that are really helpful that would strongly support that this was a seizure event is tongue biting, especially the side of the tongue. That's very common during the seizure, so patients will often have some bleeding from their mouth. You want to look at their tongue. And urinary incontinence is also really common when someone has had a secondary generalized seizure. Now, unlike, let's say, a partial complex seizure where patients may come back to normal pretty quickly, if someone's had a secondary generalized seizure, they're confused for a good 20 to 30 minutes afterwards. And we call that the post-ictal period. So the ictus is the seizure, the event, and then the post-ictal period is after the seizure is over. So, for a first seizure, of course, the family's going to call 911, the paramedics arrive, and the patient is not responsive. Okay, now they're gradually going to come around, usually after about 30 minutes or so. Usually patients build up a lot of acidosis during a seizure, and so they kind of hyperventilate and overbreathe to try to correct that during the post-ictal period. So they have some hyperventilation during that time. All right, so one common childhood epilepsy syndrome that fits in this focal onset category is benign or childhood epilepsy with centrotemporal spikes. And frequently the other terms are not used often. So like when we talk about lateral medullary syndrome, not many people use Wallenberg's syndrome, But here, benign Rolandic epilepsy is so commonly used, probably more often used, that it's worthwhile knowing that term as well. So as the name indicates, this is a benign seizure syndrome, and it has a very quite specific finding on EEG. So about 20% of all childhood epilepsy syndromes are of this benign Rolandic epilepsy form, which usually has a peak onset between ages of 7 and 9. And so this is a focal onset seizure because the focus is usually around the facial motor sensory cortex. And so these children have initially seizures with facial twitching and numbness. And it's focal aware, so they're completely aware of what's going on. But because of the intense seizure activity involving the facial motor sensory cortex, they're usually unable to speak and may have a lot of drooling during the event. So you want to talk to these kids and they'll describe, you have a lot of numbness, facial twitching. Now, these usually start out occurring mainly at night. And so probably most of these kids have had a lot of these before a parent, or if they sleep with a sibling or something like that, identifies and observes one of these seizures. And so oftentimes the diagnosis occurs when this focal aware seizure then spreads to the rest of the brain and they have a secondary generalized seizure. And that would often be just the noise of that might trigger a parent to come in and see what's going on, or they may have one during the day. And so this story, if you hear a child that describes facial numbness and twitching and they can't talk, and then maybe they've had a big seizure, suggests this diagnosis. Has a really good prognosis. Now, I do not expect you to recognize EEG patterns, with one exception in this lecture, which I'll talk about, but as the name indicates here, with central temporal spikes. And so when we have these EEG electrodes across the brain and we're measuring the electrical activity in the brain, in this condition, the F stands for frontal, P is for parietal, T is temporal, O is occipital, and what we can see here is we get these sharp waves. So these are abnormal that are occurring in the temporal region, and C here in the central region. So you see that kind of an EEG pattern in a child with that story, and you're pleased with that because it has, overall great prognosis. Now, before we get on to generalized seizures, just one other thing that's often a diagnostic dilemma is a patient is alone and they find themselves on the floor. They lost consciousness. And so you're trying to determine, well, did they just pass out? Is this a syncopal event or did they have a seizure? And so here are some things that can be helpful. First of all, you want to ask the patient, what's the last thing you remember? Did you have any symptoms prior to this? And if the patient says, and you can kind of go through some of these partial simple questions. If they report deja vu, or, it was really strange, I got a bad taste in my mouth, or something like that, then that would really support that this was a seizure. If, on the other hand, the patient said they felt very lightheaded and dizzy, you'll notice I did not have that as one of the partial simple symptoms. And so that would suggest more likely that this was a syncopal event. If there's a trigger, that's not common for epilepsy. Epilepsy is not usually brought on by something, although there are some exceptions. But in a syncopal event, like standing up, if the patient says, last thing I remember is they stood up, they got a little dizzy, well, then that's almost certainly suggests you're dealing with orthostatic hypotension. Or if there's some trigger for a vasovagal syncope, like the patient was experiencing some pain, or they were having their blood drawn, or something like that. Of course, they're not going to be alone in that situation, but maybe straining to have a bowel movement or an intense coughing, something else that could trigger vasovagal syncope. Remember, urinary incontinence and lateral tongue biting suggest a seizure. Okay, so that would be a point, in that direction. So you'd always want to ask about that in someone who has a loss of consciousness. And if the patient feels like it was pretty brief, like maybe they're watching TV And so they can sort of tell how long it lasted. And if it was really short, that would suggest a syncopal event is more likely. If it took them quite some time to come back to normal, they feel like there was a long gap in time, then maybe more likely a seizure. All right. So, and then just sort of even after they come to, when a syncopal event, patients feel back to normal in a short period of time. In a seizure, it takes a little while to sort of get fully back to normal. Now, moving on to generalized seizures. So the obvious question here is, how could something cause seizure activity throughout the whole cortex at the onset? And so for most generalized seizures, it's felt that there's an abnormal thalamocortical radiations. So here's the thalamus, and the thalamus has diffuse connections with the entire cortex of the brain. Sometimes it may be lower down, maybe in the reticular activating system, but for most generalized seizures, thalamocortical, abnormal electrical activity is the etiology. So again, since the thalamus talks to the whole cerebral cortex, it can therefore activate the entire cerebral cortex at onset. But again, that does not necessarily mean it's a big, grand mal type seizure. So for example, absence seizures are just brief staring spells. So it's a generalized onset seizure that you really should only diagnose in children. So you should not be diagnosing this in adults. There are some very rare syndromes where absence seizures can persist into adulthood, but if you're seeing an adult who's having staring spells, this is not the diagnosis. All right, so this can look a little bit like a partial complex seizure. So both patients are kind of having these episodes where they're confused. But absence seizures are very brief, usually no more than 10 seconds. And unlike a partial complex seizure, where you get these very stereotypic complex automatisms like lip smacking, in absence seizures, there's just a little bit of eye fluttering. Absence seizures are almost always triggered, and this can be done in the office, by hyperventilation. So just have the child hyperventilate a little bit, and you will often see then a flurry of seizure activity. And so absence seizures are often brought to attention initially by teachers because the children are zoning out in class. They're not picking up on things. Their school performance is going down. So that is quite often. There is a genetic basis, although there isn't a single genetic gene lesion that's identified. About half have a first or second degree relative with epilepsy, so there clearly is a genetic basis. And there is a very specific EEG finding, which again is often triggered by hyperventilation. So when we're doing this EEG testing, we'll have the child overbreathe during the test, which will often bring that on. Most interesting story I've heard about this hyperventilation was a boy who played trumpet in his band, and he was brought for discipline and counseling because they'd come to the end of a piece and, builds up to a climax. He's breathing harder, it's getting louder, and then that would trigger a seizure. So the band would finish the piece, and then he would blast out the last few notes after everyone else was finished. Well, that just turned out to be an absence seizure. He wasn't, being rebellious or doing that on purpose. So usually prognosis is really good for absence seizure. So this, improves, usually goes away with time. But because of the poor school performance and often just difficulty with socialization, having frequent seizures, or you're trying to play sports like baseball or something, and you don't want to be having a seizure as the ball is coming at you. So these are usually treated for a period of time just to improve quality of life. Good prognosis. So here is an EEG in absence seizure. And the big picture that I want you to get out of this is that, first of all, notice that this is occurring everywhere in the entire brain. So it's generalized. All of the cortical neurons are affected. And so the seizure pattern in absent seizures is called 3 hertz spike and wave. Now, in between these green lines is 1 second in time. Okay, so what we're seeing here is in that period of time, we have 3 of these spike and wave patterns. You can see there's a spike followed by a wave. And so we get 3 of those within 1 second, okay, about 3 per second, and that is diagnostic of absence epilepsy. So the EEG really just nails down the diagnosis. EEG is usually not specific. It'll tell us if we're dealing with a generalized onset or a focal onset seizure, but it doesn't usually tell us the specific seizure syndrome. This is one exception to that, absence seizures. So we'll talk about treatment, what medications are used in our next lecture. So next we have primary generalized seizures, and these, if you just look at the seizure itself, it's indistinguishable from secondary generalized seizure. So the crying out, the tonic-clonic phase, postictal phase, all of that looks exactly the same. All right, but it's helpful to know that overall, when you see a big seizure, the primary generalized seizures only makes up about 15% of them. So this is less common, but it is really important to distinguish because you're going to treat this differently than you would a focal onset seizure with secondary generalization. Use different medications. So one clue, someone's had a seizure, and these patients will have none of the partial, simple, partial complex onset, right? So they're not going to have deja vu or all of that. They're not going to have the automatisms prior, to the large seizure. But EEG will also be very, very helpful. So we're going to come back and explain EEG here in more detail. But again, notice here that we're seeing seizure activity throughout the entire brain. Frontal, central, occipital, temporal, parietal, it's everywhere. And so again, that is reflective of all of the cortical neurons being affected during the seizure. Okay, another type of generalized onset seizure are myoclonic seizures. Myoclonus we've all experienced. Myoclonus can be epileptic or non-epileptic. But that experience we've all had when you're falling asleep and your whole body jerks and it sort of alerts you and it's annoying, that's myoclonus. And that's sort of what a myoclonic seizure looks like as well. They're brief jerks. And so probably the most common myoclonic epilepsy syndrome is called juvenile myoclonic epilepsy. And this usually occurs in teenagers, and the initial symptom is usually myoclonus, especially within the first hour of waking up in the morning. And so often the story is dressing or trying to eat a bowl of cereal before school, and the arms and hands are twitching. Okay, so that story would be concerning, that this is what you might be dealing with. Over time, they develop other types of generalized onset seizures. So they may have absent seizures quite commonly, or primary generalized seizures, the bigger ones. Okay, so that kind of story in a teenage onset suggests this diagnosis. And so they have kind of a typical EEG pattern, about 4 to 6 hertz generalized polyspike and slow wave discharges. So EEG is quite helpful to confirm the diagnosis. They respond very well to seizure medications, which we'll talk about next time, and seizure frequency improves over time. And a fair number of these patients may be seizure-free many years later. All right, so the EEG here, again, the big picture I'm trying to point out is, look, it's generalized. So you know this is not a focal onset seizure disorder, it's generalized. And in juvenile myoclonic epilepsy, we get these kind of polyspikes that occur in this generalized pattern. All right, generalized atonic and tonic seizures. These are often mentally retarded children that you might see wearing helmets, and they have these episodes. Atonic seizure would just be where they completely lose muscle tone and fall to the ground. And so they wear helmets to protect themselves because of that from head injury. Or a tonic seizure would just be where you get pure stiffening. Okay, you don't get the tonic and clonic movements, but just these brief kind of stiffening episodes. Now, status epilepticus is a continuous seizure type that is a neurologic emergency. By definition, this is a seizure that lasts more than 5 minutes. And so the neuronal death occurs. There are actually several different things that can cause this, but overactivation of NMDA receptors with influx of calcium and potentially neuronal death then occurs. And so you want to treat this because you're trying to save neurons. Okay, it's not healthy for the brain to have prolonged, continuous seizure activity. So in kids, this can present with a seizure that just lasts for 30 minutes, an hour, 2 hours. In adults, it's more likely it presents as a big seizure and then they don't wake up, and then they have another big seizure and they don't wake up. So we would still call that status epilepticus. Okay, in our lecture tomorrow, we'll go over how you treat status epilepticus. So any seizure type can present with status epilepticus. You can have a partial complex status epilepticus, where the patient has these continuous confusional episodes with the automatisms. So there are many different causes. A large stroke can occasionally cause status epilepticus. Frequently, patients that have epilepsy that are on maybe 1 or 2 seizure medications, if they abruptly stop their seizure medications, so it's non-compliance, then that not only do they have seizures, but now they're withdrawing off of a seizure medication, and so that can cause them to go into status epilepticus. An anoxic event, like a prolonged cardiac arrest, distorts neuronal networks in the brain and can cause status epilepticus. If we have severe metabolic abnormalities, so hypoglycemia or hyperglycemia, really low sodium, renal failure, any really dramatic metabolic disturbance can trigger status. And certain infections, so like an encephalitis or a systemic infection. I'm going to come back and talk about anti-NMDA receptor encephalitis as one potential cause. Severe head trauma, again with cortical dysfunction, and brain tumor. Occasionally the onset of a brain tumor is diagnosed by a seizure or status epilepticus. All right, so it really would be good if we had a lecture probably on all of the different non-infectious causes of encephalitis, sort of autoimmune encephalitis, but I think this is the one that would be highest yield for you to know for boards. So encephalitis, remember by definition, it's not meningitis where it's just an infection of the covering of the brain, but an encephalitis involves the brain itself. And so that swelling frequently causes headache, fever if it's infectious, cognitive changes, and seizures occur in most types of encephalitis. If the brain swelling mainly involves the language-dominant hemisphere, then some degree of aphasia can occur. Now, anti-NMDA receptor encephalitis frequently involves a lot of the limbic system as well. And so most of these patients have quite profound psychiatric manifestation. So, they're having delusions and very unusual thought patterns. A number of these patients have been admitted to a psychiatric facility or the psych unit of a hospital, and then they have a seizure, and then everyone is aware, oh, this isn't just psychosis. This is actually a primary neurologic etiology. Autonomic instability is common, so blood pressure, heart rate fluctuations, and this is something that's generally seen in younger individuals. It would be very uncommon to see this over the age of 45. So if we do a lumbar puncture, we can detect the antibodies against the NMDA receptor, and here would be probably your board question here, that in women over the age of 18, these are highly associated with ovarian teratomas. Okay, so we'd always want to look for that. We can do ultrasound or CT studies to look for the teratoma, and then if you remove that and good prognosis. So some of you might know this is a very popular book called Brain on Fire, My Month of Madness, which is a really good book, a patient description of what it was like going through the experience of NMDA encephalitis. Okay, and just kind of an interesting drawing here showing you the relationship between the ovarian teratoma and how that may secondarily then through, sort of like a perineoplastic process, then involve the brain. All right, so we can have focal status epilepticus, for example, a partial simple motor seizure or a focal aware motor seizure. So we've got maybe a stroke or a tumor or something involving the motor strip. Some of these patients can have just continuous facial twitching and hand twitching for months, and it may never stop. That can be very refractory and difficult to treat with seizure medications. It's very useful to know about this condition, non-convulsive status epilepticus. So this is a form of status epilepticus where the patient doesn't have obvious outward manifestations like tonic-clonic seizure activity. These patients just present as kind of a goofy, confused patient. So it's important in our differential of someone who is confused. Usually the diagnosis is going to be pretty easy, right? You'll find out they're taking too much of their medications or they've got some electrolyte disturbance. But if you're going through and you're not able to find out why the patient is so confused, all the metabolic testing is normal, your brain scan is normal, maybe you've even done a lumbar puncture and it's normal, keep non-convulsive status epilepticus in your differential. We'll come back to this in our coma encephalopathy lecture, but if your cause of confusion is unknown, you should do an EEG, because an EEG then will see that the patient is actually having seizure activity, and that's the reason for the confusion. Now finally, this is surprisingly common where someone has what are called non-epileptic seizures. The older term pseudo-seizures is still very commonly referred. So I'm always amazed that this study, up to 25% of patients referred to a tertiary medical center for seizures end up having non-epileptic seizures. So these are associated with psychological factors, depression, anxiety, sometimes can be a conversion disorder, sort of the manifestation of underlying stress, or malingering. And so I've seen patients who were trying to explain maybe a violent episode, and it was saying that these were seizures. That would be malingering, very conscious awareness of, faking something for a secondary gain. Or a patient is suing someone because they slipped and fell in a grocery store, and they say they have seizures as a result of that. So that would be kind of a red flag. There's some obvious secondary gain, and so the events may not be epileptic that the patient's describing. Now, this makes it very confusing, but up to about 1 in 3 patients who have epilepsy also have some non-epileptic seizures as well. And this would be more common if someone's experiencing a lot of stress, and having seizures can be very stressful. So you always want to be aware of that. You're seeing someone with epilepsy, get a description every time of the events they're having to make sure are these really epileptic events or non-epileptic events. So some clues that you're dealing with a psychogenic non-epileptic seizure. The movements are quite atypical. And again, I have quite a few videos for you there on Canvas that you can look at to observe some psychogenic non-epileptic seizures. Movements are more likely to be wild thrashing movements. A real seizure is quite a stereotypic crude movement. Tonic-clonic seizure activity, it's quite typical for most seizures that you will watch. But in a psychogenic event, it's more just kind of thrashing around. We may have side-to-side head movements, which would not be common with a genuine seizure. We might get, the right arm has a little jerk, and the left arm has a little jerk, and the legs jerk a little bit. Oftentimes, I was at a conference once, and an epileptologist said he calls these relaxed seizures. in comparison to a genuine epileptic seizure, where then everyone's blood pressure goes up, you call 911. In a psychogenic non-epileptic seizure, sometimes the family will say, well, we let him lie there on the couch for a few hours, and it didn't seem like he was getting better, so we thought we should bring him in. It's not quite the intense episode that you see in a genuine electric seizure. Pelvic thrusting also usually suggests that it's a non-epileptic event. So again, events that last for hours at a time. Remember, like a secondary generalized seizure lasts about 1 to 2 minutes. So these are often long-lasting events, often triggered by an emotional stimulus. So every time the in-laws come over, that's when the individual begins to have seizures. That's not a typical story for epileptic seizures. It should be a red flag if a patient doesn't respond to any medications. Now, we can have refractory epilepsy that doesn't respond well, but usually patients that have epilepsy respond very well to medications. So you're seeing someone, they're on 3 medications, it does nothing, should at least make you think that maybe these could be pseudo-seizures. A psychogenic non-epileptic seizure, when it stops, the patient will often just return to normal immediately. They don't have that long post-ictal period that you see in a genuine epileptic seizure. Not too long ago at the VA hospital where I work, I was on call and was told that there's a patient in the emergency room having a seizure. So I walked right down, opened the emergency room door, and I could sort of see through the curtain the patient was still shaking. I walked into the room, and the patient stopped shaking and opened their eyes and said, "Hello, doctor." And that just would not happen with a generalized epileptic event. Patients don't wake up immediately. So again, if you're finding an obvious secondary gain, then that should be a red flag. And in a really interesting study, it was found that in a psychogenic non-epileptic seizure, almost always the eyes are closed, whereas in a genuine seizure, look at that, in 152 out of 156 patients, the eyes were open. So if you're talking with a witness, or if you're observing an event, are the eyes open or the eyes closed? That can be quite helpful. Now, if we can do this within a short period of time, prolactin levels go up after a genuine epileptic seizure. They are not affected in a pseudo-seizure. So we've got someone in the emergency room that has an event draw a prolactin level. Okay, so again, just to come back to etiology, frequently we don't find the cause. In children, it's frequently hereditary or associated with high fever. We do like to ask about history of birth trauma. So if you're having a child that has seizures, was it a difficult delivery? Were there complications? Encephalitis, which again we would often see more in younger individuals. In adults, more likely stroke. And interestingly, seizures after a stroke usually begin like 6 months later or a year later, less likely in the acute context. Head trauma, so again you're seeing a 45-year-old man who's having new seizures. Well, like where I work at the VA, naturally you'd want to ask, did you ever have any significant head trauma? And if there was a significant event where they were unconscious for a long period of time, maybe after a blast exposure in Iraq, then the head trauma can cause some scar formation in the brain, which years later frequently will lead to seizures. I mentioned last time that arteriovenous malformations often present with seizures or a brain tumor. So always do a careful drug and alcohol evaluation. Again, benzodiazepines. Always want to ask about benzodiazepine use and a change in benzodiazepine use as a common cause of seizures. Also alcohol withdrawal. All right, so here's a case history here. 62-year-old man complains of 1 year of recurring spells of leg shaking that last 1 to 2 minutes without loss of consciousness. More recently, he feels his gait is clumsy and he's had urinary incontinence. Came to the emergency room after a leg shaking episode that led to shaking of his arms and loss of consciousness. Took him about 25 minutes to regain consciousness. His neurologic examination reveals hyperreflexia in both lower extremities with clonus in both feet. An MRI of the brain is shown. And so this is actually not a very common condition, but because I know it has been asked on boards, I thought we'll just go through this case study. And so what we see here is that in a sagittal section of the MRI is we have a midline mass. And this mass is right in the area of the paracentral lobule. And anytime you see a nice, homogeneous, well-circumscribed mass on a brain scan, that's usually going to be a meningioma. And meningiomas will often grow in this midline sort of parasagittal location here. And there'll be a little swelling in the brain from the mass effect here. And so this is a meningioma that is affecting the paracentral lobule. That's where the legs are. So that's why the patient, it's triggering seizures here by irritating these cortical neurons. And the mass effect then is giving the patient some leg weakness and some of the hyperreflexia that we're seeing on examination. So we would classify this initially as partial simple motor seizures or focal aware, right, because the legs were shaking and the patient was aware. But then the patient had an event where the seizure focus spread and they had a secondary generalized seizure or a focal to bilateral tonic-clonic seizure. So the MRI does explain the patient's symptoms. And in this case, you'd want to remove the tumor, and that is likely going to then prevent more seizures, or the patient may need to be on a seizure medication for a period of time, depending on how they do. All right, now let's finish up talking about EEG. So I don't think you need to know a lot about EEG, but you do need to know how the waveforms are generated. So the big picture is they are generated by the inhibitory and excitatory postsynaptic potentials of cortical neurons. And so just to emphasize that, I'm just going to read this sentence here. So the fluctuations in the surface EEG are produced mainly by the temporal and spatial summations of electrical currents caused by the relatively slow postsynaptic potentials. So excitatory or inhibitory postsynaptic potential with little or no contribution from the brief action potentials. So let's explain what that means. Here we have a cortical neuron, and so there is inputs here to the dendrites or to the cell body, and these can be excitatory, as we see here. These can be inhibitory, and these have a very prolonged effect here, either generating excitatory or inhibitory postsynaptic potentials. Okay, now of course that may trigger the neuron to fire an action potential, okay, but what we're actually seeing when we look at the brain wave activity on an EEG, either upward or downward deflections, are these excitatory postsynaptic potentials. Excitatory or inhibitory postsynaptic potentials. And so if we're seeing the patient, maybe they're coming in for, usually it takes about 45 minutes to do an EEG. We'll, with some glue, put these electrodes all over the brain, and we can even send a patient home with something like this, where the electrodes here are each, measuring that electrical activity in different areas of the brain. All right, so these electrodes feed in here to our computer, and so in real time, then we can watch what is going on with brain activity. And so the big picture here with EEG is it's so helpful to determine, is it focal onset, is it generalized onset? And so in generalized onset, we see the abnormal sharp wave activity occurring throughout the entire brain. Okay, and again, next time we're going to say how you treat that differently than a focal onset seizure. So in a partial or a focal onset, well, notice here we just have the seizure activity occurring in these focal areas of the brain. It's not occurring everywhere. Okay, so now in this case the EEG will tell us, again, you don't need to know this, but the odd numbers mean the left side of the brain, the even numbers mean the right side of the brain. So here we see most of the seizure activity occurring here on the left side, here in the parietal central region, and we can see some of that here in the left temporal region. Okay, so you see that, obviously this is a patient that needs a brain scan because something is going on in the left hemisphere of the brain. Now, an EEG, someone does not need to have a seizure during the EEG for you to detect abnormal activity. So our yield in someone that has epilepsy on a first EEG is about 50 to 60% likelihood that we'll see some seizure activity. And so we often need to do a second or a third EEG, and our yield does go up. You can see almost to 90% of finding seizure activity by a third EEG. Now, there are some locations, especially the frontal lobe, where that can be notoriously difficult to pick up on EEG. So again, the point of EEG is it can tell us, is it focal or generalized? That's going to guide therapy. Or it's just going to tell us, does this look like the patient has seizures or not? And so someone that has non-epileptic seizures will have a normal EEG. And so obviously it's helpful if you can catch someone with non-epileptic seizures during an EEG, and that's often when we'll do video EEG. So someone is having multiple events every single day, and your EEGs have been normal. Well, bring them into the hospital where we can do EEG activity. We also put a video camera on the patient so we can video record the events. And then if you have the patient and they have several events and the EEG is normal, and then you get to see what the events look like, and you can tell it's not typical for seizure activity, now we can really confidently diagnose non-epileptic seizures. Okay, so we'll stop there, and next time go over anticonvulsant medications.